Hello, my name is Jennifer Ottowitz, and I'm a rehabilitation teacher at the Badger Association of the Blind and Visually Impaired. I work with adults who are losing or have lost their vision. This video covers vision impairment and blindness. My colleague, Jerry Niedermeyer, will also be joining us to share tips later on. In your work as a CNA, you will most likely come in contact with people who are blind or visually impaired. You may or may not be able to recognize that they have a vision impairment. But the information and tips covered in this video will help when assisting all patients or clients, especially those with vision impairments. Vision loss alone does not affect a person's ability to hear, their intelligence, their ability to walk, or their need for self-esteem and independence. People who have recently lost their vision may have difficulty at first adjusting to the many changes in their lives caused by the vision loss. They may need more assistance at first, especially if they do not know about adaptive aids or skills yet to help them remain independent. People who have lived with their vision loss for some time may already know about these skills and adapted aids. Always ask the person if they need your help and how they would like you to help before doing things for them. Remember, you must treat your patients or clients who have a vision loss or who are blind with the same respect and dignity as you do all your patients or clients. Having a vision impairment means having difficulty seeing to read, recognize faces, view things far away, or seeing only part of the environment, even with your glasses on. There are several myths about blindness and visual impairment. Myth: people with vision impairment or blindness see nothing at all. Actually, only about 10 to 15% of people with loss or who are legally blind see nothing. Most see some light, color, forms, or movement. Myth: people can correct their vision just by wearing glasses. Glasses cannot correct all vision impairments. The need for glasses depends on the extent and cause of the vision loss, as well as other factors. Myth: nothing can be done to assist those with visual impairment and blindness. With proper training, adapted aids, information, and support, people with vision impairment or blindness can develop good self-esteem and increase their independence. In most cases, they can learn to live on their own, raise families, work, and be a part of the community. Myth: all eye conditions get worse. Some eye conditions do get worse, but this may happen slowly over time. Some remain stable, and some change from day to day. With proper care and treatment, many eye conditions do not lead to total blindness. Myth: all eye conditions can be corrected with surgery. Although surgery does help some eye conditions, many cannot be totally fixed with surgery. Surgery is often done to prevent vision from getting worse instead of making it better. There are several common signs that may indicate a person has a vision loss. These include squinting, knocking objects over when reaching, overreaching for objects, sweeping with their hands to locate objects, probing in front of them with one foot when walking, bumping into objects when walking, placing and moving their arms in front of them when walking, and always looking down when walking. Some common eye conditions you may come across in patients or clients with vision impairment include age-related macular degeneration. This is often considered an age-related eye condition. For example, it is associated with individuals age 55 and older. It affects central vision, which makes reading and recognizing people's faces difficult. It does not lead to total blindness because side vision remains. Color vision may also be affected. Diabetic retinopathy can occur in people who have diabetes. Vision impairment occurs when abnormal blood vessels leak into the back of the eye, known as the retina. This is associated, as I said, with long-term diabetes. If left untreated, it can lead to total blindness. It often makes reading, shaving, or threading a needle and other daily activities and near tasks difficult. With cataracts, as we grow older, the lens of our eye gets cloudier. Often, vision becomes hazy. The treatment is often to remove the cloudy lens and replace it with a clear lens. With glaucoma, the inside of the eye has very high pressure. If left untreated, it could lead to total blindness. It affects side vision and usually progresses very slowly. When working with people who are blind or visually impaired, there are several tips which you may find helpful. Identify yourself when entering the room. Ask before offering assistance. Don't assume that help is needed. Do not touch the person without identifying yourself first. Describe what you are doing or why you are there. If objects in the room have been moved, put them back where you found them, or tell the person where they are now located. When giving directions, don't point or say things like, over there. Use real terms the person can relate to. For example, to the left of the door, or 3 feet in front of you. Do not shout or speak loudly unless you know the person also has a hearing loss. Feel free to say words like look, watch, or see. They are part of our everyday language. Let the person know whenever you leave the room. And act naturally and be relaxed. There are several daily living activities with which people may need assistance. In caring for eyeglasses and magnifiers, you may need to check and ensure on a regular basis that the glasses and magnifiers are clean. When they are not being used or worn, they should be in a case or in a safe place. Do not rest eyeglasses with the lenses down. When assisting someone with a meal or for an activity, the clock face can be a helpful method to describe where things are located. For example, your chicken is at 8 o'clock, peas at 4 o'clock, and your milk is next to the plate at about 10 o'clock. When doing this, it's important to remember that the person is located at the 6 o'clock position, and everything should be presented from that reference point. You may assist patients or clients with reading. You may need to read menus, mail, or other written information about activities, procedures, or care. It's important to encourage independence at all times. Persons with a vision impairment or blindness are generally able to take care of themselves, but if assistance is needed, try to get the person as involved as possible. Encourage them to try things for themselves. In addition, there are several aids and appliances which can help your patients or clients be more independent. Many people listen to books on cassette tape using a special machine available from the Talking Book service. Signature guides are used to help the person stay on the line when signing their name. Other writing guides help a person write checks or address envelopes. Dark felt tip pens and bold line paper also help when writing. Many items can be marked in various ways to help the person identify them by touch. Rubber bands, tape, and raised dots are a few things used for labeling. Having talking or large print clocks and watches help people follow their daily schedule. There are many other aids and appliances available to help do a wide variety of tasks. Check with the resources listed in this section for more information. At this time, my colleague, Jerry Niedermeyer, will discuss orientation and mobility skills.
I am Jerry Niedermeyer. I'm a certified orientation and mobility specialist at the Badger Association of the Blind Visually Impaired in Milwaukee, Wisconsin. I have a master's degree in blind rehabilitation, orientation mobility specialty, and I've been teaching orientation mobility to clients and individuals for over 25 years. What is orientation and mobility? Orientation and mobility means knowing where you are in the environment at all times and being able to get there safely and efficiently. In other words, we want your patients to get where they want to go and back without getting lost or sustaining injury, and to get there on time. There are some orientation and mobility techniques which you may be able to use when working with your patients who are visually impaired or blind. The first is what we call sighted guide. A sighted guide is a person who has sight and walks with a patient with vision impairment or blindness and takes them where they need to go. Here's how we start sighted guide. Have the patient gently grab your arm slightly above the elbow. The patient then places himself or herself 1/2 step behind you. You then walk forward with your patient. How fast you walk will depend on how fast your patient can walk. And don't be afraid to walk with your patient and describe activities and happenings occurring around them. Let them know when you are approaching a ramp or even a curbing if you're outside and going to a store or a doctor's appointment, etc. Walking through narrow spaces. There will be occasions, such as in a crowded dining room, when your patient can't walk next to you because of a narrow space. You tell your patient there is a narrow space coming up and place the arm your patient is grasping behind your back. You then instruct your patient to get directly behind you and to straighten the arm they are holding onto you with all the way out. This will prevent them from stepping on your heels as you walk. You are now leading the way through the narrow space for your patient. When you are through the narrow space, simply let your arm drop to the regular position and continue on walking. Stair travel. Stairs are always dangerous. It is very important to make sure you always talk to your patient and let them know when you are going to use a stairway or even a single step, including a curb. So always talk to your patient when you're walking with them and describe their surroundings, especially if they're in any unfamiliar areas. For both going up and down stairs, it is important to you as the guide to stop briefly at the first step and let them know if it is a stairway going up or down. Your patient will be right next to you. You then take the first step and proceed at a pace your patient takes. When you reach the landing, let them know you are on the landing and that they have just one more step to take. Seating. When you have reached your destination with your patient, they may need to sit down. When you reach the seat, you can reach across your body with your free hand and gently grab the hand that they are using to hold onto your elbow with, and then place their hand on the back of the chair so they will know where the chair is. You can then assist them in pulling the chair out so they can position themselves to sit down. Before they sit down, however, have them sweep the seat with one of their hands to make sure there is nothing on the seat, such as a spill or a book. For couches, it's best to have your patient contact the front of the couch with the front of their lower leg so they know where it is. They can then turn and sit down on the couch, but first have them check the seat again to make sure they aren't sitting down on anything. When you and your patient are walking in the standard sighted guide position, you tell your patient, we need to turn around and go back the other way. To facilitate that, you have your patient turn towards you. You both turn towards each other, and then you have your patient grab the other arm for the sighted guide technique. And this way you're not taking up a large area as you make your turn, just the area that you're standing in. Then you continue on your way. Protective techniques. The upper hand and forearm technique is used when your patient needs to protect their upper body from things like partially closed doors, the edges of doorways, a tall laundry cart, other patients, or even staff. We ask the patient to place either arm at chest level with their elbow bent at a right angle with the fingertips extending to their opposite arm. This will protect their entire upper body as they walk. Generally, we use this for small and familiar areas. The lower hand and forearm technique is used when your patient needs to protect their groin and stomach areas from such things as dining room table corners or other objects at waist-high level. Have the patient place either arm downward and across their abdominal area with the hand extended down to the groin area. And your patients can use both techniques at the same time whenever they feel the need to be extra careful. The next technique we use is called trailing. We use trailing when we want patients to walk to a destination by just following the wall to get there. We have them stand next to the wall, about 12 inches away from the wall, and gently place the back of their hand against the wall so their hand will also be about 1 foot in front of them. This can help them walk in a straight line and be out of the main traffic flows in corridors or in a room. They may use the upper hand and forearm protective technique at the same time. The next area I want to discuss with you is called orientation skills. Orientation means knowing where we are in space at all times. This means we will want our patients to know the location of the dining room, the nurse's station, the beauty parlor, and other important areas from their living area or room. Knowing where different locations are improves their independence, can also enhance their self-esteem. To help them understand how to determine where these areas are, we have a couple of strategies we use to assist them. The first to use is what we call landmarks. A landmark, by our definition, is any familiar object, sound, odor, or temperature that has a permanent location in the environment and is easily always recognized. Some examples of landmarks will be the nurse's station, a fire extinguisher wall box, a drinking fountain, a buffet table, a piano, or things of that nature. These are places that will help your patient determine where they are in relation to other places in your facility. We also use clues. A clue is any sound, odor, temperature, or tactile stimulus affecting the senses that can be readily converted in determining their position, but it will not be permanent or always available. Examples of clues are smells coming from a beauty parlor, or sounds from a television set, or sounds or voices in a busy dining area. Clues are less reliable because they're not always present. The next thing I want to discuss with you is travel with a white cane. White canes have white and red pieces of reflective tape on them that shines when light hits the tape. The tape helps mostly outside when a blind or visually impaired person is walking at night. This refers to a cane used for mobility, not a support cane, which persons use for assistance when they have difficulties in walking. A person with vision impairment or blindness who uses the white cane or long cane has been taught by certified teachers like myself on how to use them. You must not attempt to work with patients on how to use this type of cane. If you notice a patient with a long cane having difficulties, pass this information on to your supervisor so they can contact any of the agencies listed at the end of the video. A certified teacher then can work with that patient on any difficulty they may be having in using their cane. The next area to discuss is glare and contrast. Bright light can be very uncomfortable for some patients with eye conditions. You can always ask your patients, do you prefer sitting with your back to the window? Or do you prefer to have the lamp moved to a different spot? Or how do you like your curtains set? Glare can also cause them to see less well. It is usually best to have light from floor lamps or table lamps come from behind the patient and over either shoulder. This way the glare from the surface of their reading material or the table will be reflected away from their eyes. Contrast is a very important thing to think about. Some patients will have difficulty seeing black coffee in a dark cup or a white-colored plate on a white tablecloth. You can help with this in many ways. You can try to make sure that objects they will be using are of a different contrast for the table or counter activities. Dark tablecloths will help with white dishes. White tablecloths will help with dark dishes. White paper on a table can help with arts and crafts objects that are colorful. Let's talk about environmental precautions. There are some things we can all think about to make the environment safer for our patients with visual impairments and blindness. First of all, we need to be careful with throw rugs. While they look nice, they move on occasion and can cause falls. Make sure electrical cords are behind furniture. Extension cords are handy things to use, but they can cause tripping. Make sure extension cords also remain behind furniture and away from areas where patients will be walking. Shiny wax floors look very nice. They are also slippery surfaces. Try and use low luster waxes whenever possible. And remember not to leave cabinet or closet doors or drawers partially open. Your patients can walk into them. And make sure to push in chairs at a table or desk when not in use. It's been a pleasure for Jennifer and I to be here today to discuss blind rehab techniques and specific eye conditions that you may encounter with your patients in your facilities. If you have any questions, feel free to contact any of the resources listed at the end of the video, and we wish you all good luck in your careers in working with individuals with special health needs.